Here we'll learn the etiologies and consequences of the four simple acid-base disorders. To begin, start a table and denote that a metabolic acid-base disorder presents as an imbalance between bicarbonate, the primary extracellular buffer, and fixed, also referred to as non-volatile acids, whereas a respiratory acid-base disorder presents as an imbalance between bicarbonate and carbon dioxide, the volatile acid. Next, prepare a table to organize the four simple acid-base disorders: metabolic acidosis and alkalosis, and respiratory acidosis and alkalosis. Indicate that we'll distinguish these disorders by their arterial blood profiles, compensatory, respiratory, and renal mechanisms, and common causes. Let's begin with metabolic acidosis. Write that it's caused by either a gain in hydrogen ions and or a loss of bicarbonate, which lowers pH. Consequently, the arterial blood profile shows reduced bicarbonate concentration and elevated hydrogen ion concentration. In response to a drop in pH, the respiratory system compensates with hyperventilation. Excess carbon dioxide is blown off, which lowers the partial pressure of carbon dioxide in the blood. Indicate that the arterial blood profile reflects this. Though slower to respond, renal bicarbonate conservation and acid excretion produce a more effective and longer-lasting pH elevation. To illustrate this, draw a nephron and indicate that bicarbonate reabsorption and titratable acid and ammonium excretion increase. Thus, bicarbonate is conserved and hydrogen ions are excreted. Before we list the common causes of metabolic acidosis, we need to understand the anion gap. Write that it's used to determine the etiology of a metabolic acidosis disorder. In a routine blood test, only some cations and anions are measured. The anions that are not measured constitute the anion gap. Because the total concentration of anions must be equal to the total concentration of cations, we know that the anion gap, the unmeasured anions, must be equal to the measured cations, usually sodium, minus the measured anions, usually bicarbonate and chloride. A normal average anion gap value is 12 milliequivalents per liter. A typical range is 8 to 16. Thus, an increased anion gap acidosis indicates that bicarbonate, a measured anion, has been lost and replaced by the unmeasured ions. And a normal gap acidosis indicates that chloride is the ion that replaced the lost bicarbonate, which makes sense given that it's the other measured anion in the anion gap equation. Note that potassium is sometimes included in the anion gap equation, but its range is so small that we can remove it for simplicity. If potassium is included, the normal anion gap value is 16. Potassium is typically around 4, a range of 3 to 5, and is a cation. So ultimately, we can divide the causes of metabolic acidosis into at least two categories: those associated with a normal anion gap and those with an abnormal elevated anion gap. Common causes associated with a normal gap include diarrhea, renal tubular acidosis, and renal failure. Common causes associated with an increased anion gap include the following, which can be remembered with the mnemonic MUD piles, which stands for methanol intoxication. Methanol is also called wood alcohol, commonly found in antifreeze in industrial settings. Uremia, diabetic ketoacidosis, paraldehyde, which is sometimes used to treat alcoholism and certain convulsive and mental disorders, iron overdose, lactic acid, ethylene glycol poisoning. Ethylene glycol is commonly found in antifreeze. and salicylate ingestion from aspirin overdose. Of those we've just listed, uremia and diabetic ketoacidosis are the most common. Now let's see how metabolic alkalosis differs from acidosis. First, write that it's caused by a loss of hydrogen ions and/or a gain in bicarbonate, which raises pH. Consequently, the arterial blood profile shows elevated bicarbonate concentration and decreased hydrogen concentration. In response to elevated pH, hypoventilation retains carbon dioxide, which increases its arterial partial pressure. Indicate that this is reflected in the arterial blood profile. The nephrons increase bicarbonate excretion, and by reducing secretion of titratable acids and ammonium, conserve hydrogen ions. These actions lower pH. Write that metabolic alkalosis is most commonly caused by vomiting, in which case hydrochloric acid is lost from the body, and also loop and thiazide diuretics, which increase bicarbonate excretion in the urine. Indicate that vomiting and diuretics cause extracellular fluid volume contraction, which, as we've learned elsewhere, triggers hormonal responses that increase bicarbonate reabsorption and maintain the metabolic alkalosis. Finally, write that hyperaldosteronism, excessive aldosterone secretion, causes overexcretion of hydrogen ions. Now let's turn our attention to imbalances caused by respiratory disorders. We'll begin with respiratory acidosis. Write that it's caused by a gain in carbon dioxide and bicarbonate. The degree of change in pH depends on the duration of the disorder. The pH is more reduced in acute acidosis than in chronic because in chronic acidosis, sufficient time has elapsed for renal mechanisms to have some effect. Indicate that there's no respiratory compensation when the respiratory system is itself the source of the imbalance. To raise pH, the nephrons conserve bicarbonate and excrete hydrogen ions. Notice that this is similar to the renal response in metabolic acidosis. Write that the gain in carbon dioxide is caused by hypoventilation, which commonly occurs in response to inhibition of the medullary respiratory center, which can be induced by sedatives or brainstem strokes, neuromuscular defects that inhibit the anatomical structures responsible for ventilation, and gas exchange defects such as COPD. Conversely, respiratory alkalosis is caused by a loss of carbon dioxide. Consequently, pH is increased in proportion to the duration of the disorder. Again, there's no respiratory compensation for respiratory-induced acid-base disturbances. Show that the nephrons excrete excess bicarbonate and reduce titratable acid and ammonium ion secretion to conserve hydrogen ions. This is similar to the renal response to metabolic alkalosis. Loss of carbon dioxide is caused by hyperventilation, which blows off too much carbon dioxide and lowers its arterial partial pressure. Hyperventilation can be induced by stimulation of the medullary respiratory center, hypoxemia, low blood oxygen, and physical or mental distress. Be aware that we've only discussed the 4 simple acid-base disorders, in which only one primary disturbance is present. However, mixed acid-base disorders, which result from 2 or 3 primary disturbances, are common. This concludes our diagram.